This conference will now be recorded.
When we talk about general gynecology, really you should be keeping many things in your mind. Like maybe they will be asking you about benign gynecology. So everything, to be very honest, anything which is related to gynae, I mean that is related to the non-pregnant women, and it is not covered in any other module. It will be covered in the general module. Basically, general benign gynecology, like menstrual disorders, pelvic pain, vaginal discharge. Remember this discharge and STI, these are two different things. PID, STI, these will fall. I mean, the general complaints are going to be the same, but there can be so many other different causes. Then, management of emergency gynecology. Emergencies are not only seen in the obstetrics, they are seen in the gynae also. Then, congenital abnormalities of the genital tract, pediatric gynecology and puberty, and then endocrine disorders. Regarding the tasks, they can, frankly speaking, they can ask you about anything. What do you see here? Can you spot it? Can you identify this one? So things can be simple like this. Like here you can see that this is just a case of like ectopic, but you will have to give the differential diagnosis. Ectopic basically we covered in the early pregnancy complications like that. This one, they can show you a slide. This is just to show you that how many different things they can ask you. So you have seen a molar like that. Then like they can give you any type, like person having any type of bleeding, any sort of bleeding, what has happened, like what is this case. So as I said yesterday that today I'm going to talk the least, and I expect that you people will participate and you are going to say a lot. Okay. So, and by definition, I have told you that anything which is not covered in any specific module, you are going to be tested here. Can be a case of fibroids, can be a case of adenomyosis, okay, can be anyone having discharge, can be any small girl with a discharge. So physical examination is not part of it. So they're just telling you about a case that she has discharge or she has some other problem and she has come to you. So what exactly you think she's having? Like simple things like that, okay? And all sorts of tasks they can be tested here. Patient safety is going to again rank very high here. Don't ever compromise on patient safety. And then consent requirements, they are the same. No difference here. The causes mostly they will be like having the asking you to give the differential diagnosis. So be logical in that, okay? Don't straight away, even though you have found a diagnosis, but still you have to say like you have seen a case of endometriosis, unless they have given you the information that objective testing has been done and patient has been diagnosed to have a certain disorder. This outside that, don't commit to anything. Then you should remember that the common things, they are more frequently tested in the exam. That is very important to remember, okay? If something is like extremely rare, then what is the point in asking you about that? So that's all I will say. So let's start the circuits, and if there is any problem, anything, then I'll be explaining to you. Don't worry at all. Purpose is just to give you maximum chance, doctors.
This conference will now be recorded.
So what is your diagnosis?
Okay, this image is not very clear. If this was a sample in front of me, I would have to open it up more just to know what's inside. But to me, it looks like a chocolate cyst or an endometrioma.
Okay. What else?
What else it could be? It could be a teratoma. In general, it looks like an ovarian cyst. So it's either an endometrioma or chocolate cyst, or it's a teratoma. I would have to open it up, and to confirm the diagnosis, I would have to send it for histopathology.
Can it be torsion?
Yeah, it can be a torted ovary. This was the second question. What is the most common symptom? Because it looks like a large cyst. These large cysts can show up as a sudden, sharp, acute pain. Usually, most of the patients are young, and usually with activity or with walking or with exercise, they would have initial sharp pain. If the pain was coming and going on and off, it could be what we call a torsion-detorsion syndrome. Sorry?
Not for you, not for you. Someone's mic is echoing. Speakers are echoing.
It's written attendee 7. I'm not sure who's attendee 7.
Okay, attendee 7, mute yourself. I don't want to do it myself. Okay.
It's still on, but yeah, the most common presentation is a sudden sharp acute pain. Usually, once it starts, it doesn't go out, it doesn't go off. If the patient has it on and off, as we said, it would be torsion-detorsion syndrome. If the pain was severe and the patient did not come to the hospital within 1 to 2 days, and the pain will start to subside, this would mean that it's an infarct ovary, and it needs to be removed, as it would be filled with necrotic tissue.
Okay, that's great.
Assessing the clinical condition of the patient, it depends on pre-removing of the cyst or after removing the cyst. If the patient just came to the emergency room, we would have to assess her, go with a full detailed history, age, if she was ever pregnant or not, if she is pregnant at the moment, age, medical, complete gynecological history, when was her LMP, if she has any history of pain, dysmenorrhea, if she has pain, is it related to her periods or not? Does she have any pain during menstruation? Does she have, how's her menses? Is it regular, not regular? Is it heavy, scanty? Does she have it? Is it regular or not? Does she have any intramenstrual bleeding? Any excessive or heavy bleeding? Does she have any odor, vaginal discharge? Is it odorless or with odor? Does it?
Yeah, that is the thing. So pattern of pain is important. What were the signs and symptoms on initial assessment?
Yeah, any presenting symptoms, medical history. Does she have any? Was there any relieving or exacerbating factors for this pain or their onset? We will go with a complete medical history. Same with the surgical history and a previous surgical history. Then we will go with a systemic review of each of the systems, but mainly regarding if this is an endometrioma, we would go with signs of endometriosis. We would ask regarding chronic pelvic pain, dysmenorrhea, any chronic constipation or pelvic pain. Does she have dyspareunia? Is it deep or superficial dyspareunia? Does she have any family history of the same symptom, or does she know what she has? Is she aware of her symptoms? Is she aware of any of this kind of diagnosis? What is she expecting from coming to the hospital? Then initially we will do the vital signs: blood pressure, heart rate, blood pressure, oxygen saturation, temperature. We will proceed with an abdominal examination, and we will try to relieve the patient from the pain. We will give her any pain medication. We will ask her regarding any allergies and what kind of reaction she had to it, any history of blood transfusion. We will proceed with her with pain medications, IV fluid. We will do a systemic examination for the patient regarding starting from the head downwards. We will see if she has any pallor, any jaundice, any signs of symptoms of anemia. Regarding a focused gynecological history, if she's married, we can proceed by her consent with a vaginal rectal examination. We will see if there is any cervical tenderness, any vaginal or vulvar lesions, any cervical lesions, any cervical motion tenderness, any adnexial masses. We will see if the uterus and the pouch of Douglas is mobile or not, if there is any nodules. By abdominal examination, if there is any guarding, any rigidity, any palpable abdominal masses.
Okay. So after clinical examination, there was the suspicion was raised that she has ovarian torsion, and a diagnostic lab was done, and then
Yes.
was the picture seen. So what do you think in the now we should go for cystectomy or oophorectomy, or it can be seen?
It depends on the amount of necrotic tissue. If the patient, since the patient usually in this situation usually come young, we will try as much as possible to save the ovary. If the entire ovary seems necrotic, then we will have to do an oophorectomy, because leaving necrotic tissue would increase the chances of having infection and to have peritonitis post-op, which would be one of the complications and would increase her morbidity. But initially, we will always go for cystectomy as much as possible. Usually, one of the helpful diagnostic investigation is doing an ultrasound and to check if there is a Doppler, with the Doppler, if there is flow going to the ovary and cyst or not.
So if the tissue is seen that there is no necrotic tissue, color has changed a bit, then you think that we should still go for cystectomy, oophorectomy?
Yeah, if there is initially like bluish color, this means that there is a compromise in the perfusion. Then we will detort. We will wait a few minutes to see if the color returns. We will proceed with cystectomy. If there is no return in color and it stays black or bluish black, then we will go with oophorectomy.
Okay. So what will be your post-op care for this patient?
Regarding post-op care, if it's a laparoscopy, the patient usually stays for 24 hours. She will be initially managed with progressive diet, MPO at first. If she was because laparoscopy, she would be under GA. There would be a continuous monitoring regarding her vitals, blood pressure, heart rate, temperature, and oxygen saturation. She will be on IV fluids, and Foley's catheter would be in until she starts mobilizing and can tolerate orally. Painkillers, usually patient can tolerate the pain post laparoscopy with only acetaminophen and maybe non-steroidal. If the pain is too much, then we can give her some narcotic. If we remove the ovary, we will have to explain to the patient that removing the ovary will not cause infertility, but she can still get pregnant from the other ovary. But if same symptoms ever seem to show up on another period of time, she has to immediately come to the hospital because we have to save her other ovary.
Yes, that's great. So thank you very much. So well done. You know that it's not hard, right? So if you will try, you can do it very easily. Because like Dr. Umar, you all people have passed the exam and you have good knowledge and you can really work very well. It is just why I'm showing you atypical stations, because if you will keep doing the recalls, then maybe this time the examiners have changed their mind and they will not give you the recalls. What will you do then? So expose yourself to a variety of stations like that, okay, so that you can build up your own thinking process and each case is going to be challenging. It's hard that they will bring exactly the same case. Okay, so even if they are repeating, if you will focus, you will find that they are repeating in a different manner. So well done, Dr. Umar, that was fine. And then the points, you have to go in a sequence. What is the history of the patient? If the history is that of few hours, you have to think about acute accidents, emergencies, something has occurred. Either it's an ovarian torsion, or maybe she had like ovarian torsion, which can be totally idiopathic, or it maybe the patient had some mass, some ovarian cyst mass there, and now which has torted along its axis like that. And how you will know that this is some old complaint or this is some new complaint, because the history is very important. So you should tell the examiner that before I read, this is it looks like ovarian tissue, but I need more information before commenting on this patient. Okay, don't comment on anything which you have not seen properly or something like that. So always ask for more detail. The examiners, they are keeping many papers with them, because as if you will show me this thing, unless you will tell me that this is ovary, I can't see anything, because if it has an enlarged ovarian torsion is one thing in which the patient has ischemic insult, and then what happens, many changes, they will start taking place simultaneously. Within hours, your patient can grow their ovarian size to 20, even 20, 22-week size. And in such scenario, what you will see, that the moment you will open, you will think as if this whole tissue is coming off. It is all edematous. Wherever you will touch with the needle, it will start oozing. A lot of fluid will come out. That is one thing. Okay, so you have to see that has this area undergone necrosis or not. Color has changed, hemolyzed blood is there, and then after, your aim should not be oophorectomy. It should, if the management is now more and more conservative, like if the patient doesn't respond to the local oral analgesia, or you will not give, because maybe you will take her for the emergency the surgery, a simple paracetamol. If it is not relieving the pain, then it means that you need to open her. Then regarding the history for the ovarian torsion, from where you will get the clue, they will tell you that patient has history of mild unilateral abdominal pain, which was confined to the lower left or right quadrant of the abdomen. And sometimes they will tell you that it was referring to her knees. Why knees? Because the obturator nerve is supplying the medial side of the knee, and that one passes very close to the ovarian fossa on the pelvic side wall, where the ovaries are lying. So if ovaries are irritated or inflamed, then this obturator nerve is also stimulated, activated, so the patient can have problem like this. Treatment is mostly conservative. As much as you can save, that's well and good. So don't say that we will do oophorectomy. Say we will go for cystectomy if there is any, and we will try. Even if we have to go for oophorectomy, we will try to save as much tissue as we can, because even a very small strip is going to be very helpful for the patient, because we need the hormone in micrograms. So it will keep coming from that ovary. Okay, so it is also considered a vital organ. And then you should say that I need a bit more of history, that what is the background of this patient, because this is not spotting that I will just look at something and I will go and answer that question. Okay? So always ask for lab results, always ask for a brief history. You can say that I need to know the background history of this patient before I can proceed. If they will say that no, we don't have anything, this is only what we have, then okay, then we don't have many options, but otherwise you should always ask for something. Okay, thank you. And know about the pain pattern of the different
This conference will now be recorded.
okay, can you please start? Next station, Dr. Aisha. Okay, who is going to start now? Who's going to do this station?
Actually, I'm confused. I didn't know it's for me or for her, Dr. Aisha.
Really? Okay, Abrar, you do this one. Then I will
Me? Last. Okay.
Abrar, and the next one
Yeah.
is for Dr. Aisha. Okay, and you answer one at you.
Okay. Okay.
What do you think? What is she having?
Just a minute, doctor.
When you have to describe the diagnosis, always start with possible, what are the possible diagnoses, okay? Don't say, maybe this patient can have this chronic pelvic pain, could be other causes. So keep your horizon, your differential diagnosis very broad.
Okay.
Okay, doctor. So what's your impression? What is he having right now?
Just a minute, doctor. I didn't complete reading.
No problem. Please
Oh.
take it.
She may have an endometriosis. It's causing for her chronic pelvic pain, or may have an interstitial cystitis, adenomyosis.
Yeah.
Um,
IBD, inflammatory bowel disease, can also be something.
IBD, adhesion disease secondary to infection, or chronic pelvic infection.
Yeah. Yeah, that's correct. So what procedure has been planned for her?
What procedures it's planned for her? May will do for her diagnostic laparoscopy plus or minus therapeutic.
Okay.
If they found an endometriosis implant or adhesion, so they will do adhesolysis or ablation cautery for endometriotic implants. If there is an interstitial cystitis, May will do cystoscopy, and we will take bladder biopsy for the diagnosis.
Okay. So how you will explain to the patient? Because she has been having this pain for quite some time. Look at her age. She's only 24. So, and then what will you like to tell her? She's not taking any regular contraception, and her main complaint is that she has pain. So you will go yourself, then what will you tell her?
So we did for her the imaging technique, ultrasound and MRI. We cannot rule out or confirm any specific diagnosis. May we'll go for diagnostic laparoscopy. After that, we will proceed for the management. If we confirm that she has an endometriosis, we have a different plan for management. Either analgesia to decrease the pain, we'll start with non-steroidal anti-inflammatory drugs, or we'll try to do atrophy for this endometriotic implant by hormonal therapy. We will start with progesterone medications, or combined or contraceptive pills, or GnRH agonist, according to her response to each medications. And according to the stage of the endometriosis by laparoscopy, is it minimum, mild, moderate, or severe endometriosis? According to the degree, we're gonna proceed for the management for the light intervention or advanced intervention.
Yeah.
Mm,
Yeah, it depends upon disease severity.
yes,
So,
and also depend on the symptoms. She is only young age, Nanibara. So she's only complaining from the pain. If she's complaining from the infertility, so there is another plan of management for her. Uh,
so what else you would like to tell her? You will introduce yourself. You will take a bit of this history. You will ask her, does she have, because they have told you that generally she is fit and well. So after confirming the symptoms, you should tell her that you have been reviewed and it was found that it will be in your best interest that we should have a look inside your tummy, that what exactly you are having like that. So I want to ask you a few questions. Okay, you should ask her. So what will you like to ask her? Because the patient, if you remember, I told you that mostly we use ICE criteria. ICE is that why she have, what is her idea about her illness, then what is her concern, okay, and then
mm,
what are her expectations, okay. So you need to explore all of these things. So what you will like to ask her now?
um, what's her? What uh, seek any medical advice before, what she's thinking about her diagnosis, what is the most thing that she is worried about it, the infertility or that pain that it's affecting her daily activity and life, or what she is expecting that the treatment that we can offer for her, and what she is needing and what she is afraid of from the management and from the intervention.
Yeah, that is the thing. And then what type of procedure you are going to do on her?
Type of procedure,
Yeah, they said that we will do laparoscopy. So what will you like to tell me
diagnostic
about the procedure?
plus
Mhm.
or minus, diagnostic laparoscopy plus or minus
Laparoscopic, yes.
therapeutic. I will explain the full procedure for the patient that we're gonna do a 3 hole in the abdomen. We'll do 2 hole for in the abdomen, one umbilical or infraumbilical, and the other in either right or left lower quadrant abdomen. Um, uh, I will explain the risk and the benefit. The benefits, it's early recovery and less pain, and the disadvantages
Mhm.
that
So in
uh,
endometriotic patient, it will be easy access or it will be hard,
yeah,
difficult,
maybe
challenging.
we will find the difficulty to doing laparoscopy in patient with advanced endometriotic disease because of the adhesions. May will have an injury to adjacent organ, vascular injury, bowel injury, or bladder injury. Uh, um, may the entrance port, it will fail, so we cannot do the laparoscopy. Um,
Then
um,
if you cannot gain access by laparoscopy, what will
yes.
be your chance then? What will you do then? Because anyhow, you have to manage this patient, right? So what will you do then?
Mm, will do for laparotomy.
Yeah. So the point is, whenever you are consenting patients for the lab procedure, you are
Mm,
consenting them for the open procedures also, because maybe this patient will have a frozen pelvis and
mm,
we won't be able to do anything. So in that case, we will have to convert to laptop.
open.
That
Yeah. Mm.
yeah,
So
that's it.
I will tell her about the advantages, disadvantages, and I will explain the full procedure for the patient. I will take the consent, um, and this is about the procedure.
Yeah. So then if you are telling her about the procedure and you are telling her that maybe we can do cystectomy, we can just remove the cyst because there is a single cyst, or maybe we will have to take the ovary out, right? And then the general risk of the procedure, like pain, bleeding, infection, then
And
the risks of the laparoscopic procedure, injury to the
yes,
viscera, okay, and then
yes,
explain that she can have other complications during procedure. What can occur during procedure? Bleeding, right?
Injury to the adjacent organ, inferior epigastric artery injury, so it's causing kind of bleeding, anterior abdominal wall hematoma, uh,
Need to convert to
bowel injury. Yeah.
Intrapartum, then intraoperative bleeding can be there. That is the immediate thing. If we need requiring blood transfusion, and then maybe the procedure will be very long in case some organ is hurt unintentionally. Maybe we will
Yes.
have to call the, depends on her circumstances. Maybe we will have to involve urogynecologist. Maybe we will have to involve colorectal surgeon, general surgeon, vascular surgeon. Okay, these are the risks. Okay, then in case of emergency, she will have to stay here like that. Okay. And then we are also telling her that maybe if you will not, if there is uh, whole disease is not cured, because sometimes the tissue can be deeply infiltrating the other areas. In that case, we will have to give you medical treatment. So, what type of medical treatment you would like to give her?
Uh,
COCPs you can give. They said her periods are fine, but you are going to give suppression, right? Expectant management.
yes.
What else you can give her?
We can give progesterone like Fizan,
Mm-hmm. Yeah.
and we can give GnRH agonist for 6 months with add-back therapy or without add-back therapy, or for 2 years with add-back therapy. Um,
Okay. So why do we give back therapy? So you
our aims to do atrophy to the endometriotic
yeah.
implant. So we decrease the pain, and we increase the chance of fertility.
Vasomotor symptoms. Then there can be, yeah, vasomotor symptoms just like menopause, because it is going to stress ovarian activity. So she
Yes.
is a young woman. She is living with her husband. Then maybe you will have to give her add back therapy. So what will you like to give her in the add back therapy? So anything which contains testosterone, tivolone can be given. Why? Because it is going to produce this normal response in her. That is one thing. So first of all, you have to set the agenda that she is undergoing this procedure because she wants to conceive, or she is seeking help because she has this chronic pelvic pain. That is the one thing. Okay, so you need to explore that further. Use this ICE model. So it's very easy to remember what are her ideas, what are her concerns, what are her expectations. That is the point. Okay. So
Yes.
yeah, what else you would like to tell her? Okay, let's say that, okay, let's move on. So we did surgery, and we found that this mass, this one, like 6 centimeter one, it was found on the left side, but the right side, right ovary, also had lot of small tissue, and it was like infiltrated. They were small deposits. So we had to do oophorectomy for her because her case was so bad and she was simply devastated. So now she consented for it, that I cannot take this pain. It has ruined my quality of life. You have to ask that, always ask in the patients who are having problems, what is the effect on your life, how you are dealing with it. Okay. So the surgeon had to do this oophorectomy. Okay. So you did oophorectomy, and then after 6 months, patient returned with the same complaints. What will be your differential diagnosis now? Because you have already removed the ovaries, no ovarian activity is there. Okay, so what will be your differential diagnosis? Why she's having pain now?
So I will go with the differential diagnosis of chronic pelvic pain again. I will refine the diagnosis again. It may be psychological pain,
Okay.
maybe myofascial pain, uh, maybe interstitial cystitis also. Maybe pain from the adhesions because she's in advanced disease, so the adhesion is causing the pain. Um, Maybe PID, an infection.
Okay.
Uh, irritable bowel syndromes also it's included in the differential diagnosis of chronic pelvic pain.
Look at what have I written here. Trapped ovaries. There can be residual ovaries, right? These things can be there.
Trapped ovary,
So
trapped ovary,
yeah.
yeah, residual syndrome. Yeah.
So how you can go towards this diagnosis that she has any ovaries or she doesn't have any residual tissue left behind? How we can find it?
Hormonal profile.
Hormonal.
Maybe hormonal profiles, FSH and LH level,
Okay. And
and estrogen.
yeah. And if the ovarian hormones level was very low, what will you like to do now?
Hmm. Mm,
Don't worry. Give her hormonal stimulation again, okay? Because initially we tested her gonadotrophins in the body, like they could have come from the ovaries, okay? But the response was not there. Last year, many students
yes.
answered this question like that we will do CA125. Some said that we will like to do this hormonal profile. Some said that we will go for MRI. Okay? But
Mm,
one option is that you give hormonal stimulation before going for the invasive other extensive investigations or
procedure.
stimulation or like that because maybe some residual tissue was left behind, so give stimulation. If the level of the hormones increases, then it means that
Mm,
the tissue is still there, and if no change, then it means that ovaries are not there like that. Okay, that was the
okay.
answer.
Okay.
Okay, thank you very much. I know this
Thank
was
you.
a particularly bad session. So here you need to go there, and this is a 34-year-old patient who never had any smears. She is married and she takes coffee, and otherwise she has nothing significant. That they said that her past medical and general history, surgical history is negative. She doesn't see doctor for anything, and she has been diagnosed to have 6 centimeter mass on the left side of abdomen, and it has been confirmed by abdominal ultrasound and MRI. And when the PEVE was done, then a tender mass was confirmed, and they couldn't find any nodular masses here. They are not telling you that there were any nodularity of the uterosacral ligament, because the uterosacral ligament, the moment they will show, every doctor will think that yeah, definitely this is endometriosis like that. That's why they didn't give you. So now she has questions for you that what are you going to do? Because the patients, they are worried. So every doctor they will come across, they will ask, what will happen to me? What do you think? You must have seen many cases like me. So what should be my doctor doing now? What should my OBGYN should do for me? So everyone would have told her that they will have to remove the ovary. So she is like only 24. There is a life ahead of her, and her quality of life has been ruined. She is having dyschezia, she is having dyspareunia, her periods are fine, so nothing else is there. Okay, that is the point. So you should say, I will go and I will greet the patient, I will introduce myself, and then I will see, I will set the agenda, I will confirm her identity, and then again, this ICE one is very simple: ideas, concerns, expectations, because it is important. You will say, I will take a detailed history from her. I would like to see her ideas, concerns, and expectations. And because I will involve her in decision making, then I will ask her that, do you know about this condition? You have some idea that why we did some investigations on you, because you are having some mass, which we think that you have endometriosis, and it has been shown by confirmed by investigations on you. So now the consultant, after reviewing you, has thought that we should remove the tissues because that is the best treatment option available. What do you think about it? Okay. Then you should say that this procedure, this is called a laparoscopic procedure or a buttonhole surgery. So usually it doesn't cause any serious problems, but sometimes it can cause injuries like that. And then you should also say that I will empathize with this patient because she is having pain and her quality of life is very bad. And then you should say that I will adopt a very calm approach because the patient is already upset about her pain. So I'm going to listen to her story. I will talk in a very comfortable way, and I will make her also comfortable so that she will be able to tell her story. If she has any concerns, any problems, I will ask her that I will pay full attention to this patient, and I will establish eye contact, and I will listen to her things, whatever she will be telling me, and I will not interrupt her. The first principle of therapy is that your patient is talking, let her talk. She wants to talk for 100 minutes, let her talk. Because the moment you stop her, she gets this feeling that you have rejected her ideas. Okay, that is the worst feeling a patient can have from the doctor. So just stay calm, ask the questions. In the exam, they know. Usually, in this time there will be no player, but even when the role players are there, they have been educated that they have to talk for a certain period of time, and nobody will have watch. She will not have a watch, and you will also not have a watch. That is the point. Your posture should be comfortable, as if you have all the time in the world to listen to her story. And you should talk in a non-judgmental way. You should not be irritated, because otherwise, your patient will have more issues like that. Then you will say that I will obtain a short, focused, relevant gynecological history. That my understanding is that you have been having these pains. She will say yes, and then you have difficult pain during sex also, and even you feel pain when you are passing the stool, or when you are moving your bowel like that. And then I will ask her that what is her main concern. She is seeking treatment because of pain, or she is seeking fertility, because this is a condition which is going to cause many adhesions, and fibrous bands will be there, so it is going to restrict mobility of the tube, so it can cause tubal factor disease. Then I will say that the main purpose of the surgery is that we need to look at your tummy, and we want to remove this tissue which is causing this problem. The problem is that this tissue can be present in any organ from head to toe, and sometimes it's not possible to take out all of the tissue. So this surgery will be done by a consultant who has received adequate training, and the staff is very good. We are fully equipped. The best anesthesia will be provided to you. The anesthetist is going to talk to you about it. And then, so it will be done like depending upon your condition and the extent of disease. Either we will remove this mass, or maybe we will have to remove the whole ovary. But you don't have to worry about it, because the other ovary will be fine and you will be able to conceive. Then, as I have told you, that we can have bleeding at the port, from the port side where we are introducing these objects. Then in that case, you will have, usually we are keeping the patient for 24 hours, but if some injury occurs, then maybe we will have to keep you in for like 48 or 72 hours, depending upon your circumstances. And during the procedure, you can have this bleeding, which may necessitate conversion to the open procedure. And then maybe we will have to call the urologist, the person who looks after this waterworks, or maybe we will have to call the general surgeon, or if your gut is damaged, or if your gut is hurt, then we will have to call another one. We call them colorectal surgeons. After this procedure, you can have pain, there can be infection, or you can develop blood clot on your leg veins. The chances are low, but it can occur. In case any viscera, any organ is hurt, we'll have to fix it, and we will have to do it through the open procedure. We will have to open your tummy. You should be sure that you are going to be fine. We don't foresee any serious problems in other cases, but in your case, since this process has been going on for quite some time, so maybe this area, the wall and the other organs in the body, they may be stuck to each other, so it can cause a bit of this difficulty in entering that tummy and removing that tissue. That is one thing. So then after removing this tissue, what we will have to do, we will have to give you some medicines. Why? To suppress this activity of the ovaries, and that you will not develop any further deposits. So we will see that how you are responding to them. So these are the things. So do you think that do you have any question for me? Do you think that I have given you enough information? Okay. So she will say yes, no, or anything. So are you happy if we go and follow this plan? She will say yes or no, and then you will say okay. In that case, let me tell you I will tell you about the specific risks and the other problems, and then we can fill out a consent form, and then we can have this surgery on that day. Thank you very much for coming and talking to me today like that. So that is the thing. She will need long-term follow-up. We will give her medical treatment after the surgery. Why? Because to suppress the ovarian activity and to see her response. For how long we are going to do that? Right now we cannot see anything, but it depends upon her response to therapy. And let me tell you that there are no medical treatment is free of any side effects. You can have the same symptoms as the woman will have after undergoing menopause, like you will have this sudden surge of heat, then you will feel very cold. You can have dryness of vagina, your mood can be bad, and you may lose this desire to have sex, but we can fix these problems. Then another side effect is that since you are still in the growing phase, so your bones, they can become soft. So to overcome this problem, we'll have to give you other supplements like calcium and the vitamin D, and you need to adopt a healthy lifestyle. You need to do some physical activity, and you need to keep a symptom diary like that, because it will help us see that how you have been doing in the after your surgery. So is there anything else that I could have done, or is there something which you are expecting me to answer? Okay, I can give you this patient information leaflet so that you can go over it in your free time, and then we can once you reach some decision, then please let me know about it so that we can decide the day of your surgery. And you will say that I will invite questions, I will include her in decision making.
This
Okay, I think we
conference
can
will
start.
now be recorded.
So how you will do what will be your initial approach towards management of this young girl?
Initially, I'll start with taking history
Okay.
and taking the history from the mother and asking also the girl. And after that, I'll do the physical examination and then the investigation. Initially, in the history taking, I will ask the mother since when she noticed this vaginal discharge, and what is the color of the vaginal discharge. Is it transparent? Is it white or green, or is it bloody? um, did she notice any other thing in the daughter? Is the daughter itching the area, or is there any swelling or lesion noticed by the mother? If there is any constipation or dysuria or burning sensation while she is passing urine. I will ask the mother also about any medical or surgical history. Is the baby normal for her age and growth, and is she's going to school? Any abnormal behaviors noticed by the mother in the last few days, any change in the baby body, like breast development or hair growth. Then I will ask the mother to examine the baby with Chevron, and in the examination I'll take the BMI of the baby, and I will check the vitals of the baby, and then I will do general examination for the neck, chest, and breast and abdomen. I will examine the abdomen if there is any tenderness, or I will notice any bruises or any injury. In the pelvic examination, I will check for any vaginal discharge, any by inspection of the genitalial area. I will check if there is any vulval lesion or hematoma or bruises. I will check for any vaginal discharge, any hair growth, or to rule out the precious puberty, and if there is any vaginal discharge notice, we have to take low vaginal swab. Is it called low vaginal swab, doctor?
It's called.
Low vaginal swab. I'll do rectal examination to rule out any like a collection in the vagina. I'll do ultrasound in the investigation, and also in the rectal examination to check if there is any foreign body in the vagina. Because the kids, they might, most commonly they put foreign bodies, and I'll in the investigation I'll do ultrasound, and I'll take a low vaginal swab, and I'll do the CBC for her also, and urine analysis with urine culture. How I will treat the discharge. Discharge will be treated according to the cause. I should know the cause of the discharge, whether it is vulvovaginitis, whether it is a foreign body causing the vaginal discharge, whether it is sexual abuse causing this discharge. So if it's vulvovaginal discharge, I will treat it according to the low vaginal swab results. If it is sexually abused, I have to report it to the child protection
Services,
services, and I have to inform the social worker in the hospital to give support for the mother and the baby, and I will refer her to psychological doctor. And if it is foreign body, we have to take to counsel the mother and the parents about removing this foreign body by whether if it's near or if it's deep, accordingly, whether by hysteroscopy. Or by, if it's near, we can remove it, but we will take a consent from them regarding the virginity, and
even with the small speculum, it can be taken out. If when you are examining them under GA, you can do that. Then you have to reassure them. You have to manage regarding protocols. Please go on.
Then I will also one of the also differential diagnosis, I forget to mention it, like it could be also vulval dermatitis. I have to ask the mother if she have changed the kind of the underwear of the baby, or she's changed the soap which she used for the baby, and I'll treat it accordingly for such cases. And then I will reassure the mother according to the that the vulvovaginitis, vulvovaginitis is one of the commonest presentation for the kids, and we will give treatment, and after treatment we can give her follow-up. If it's sexual abuse, as I mentioned before, we will refer the patient to the higher authorities, and we will try to protect the mother and the child, and we will reassure them when we will give them follow-up, and we will document everything in the file, and we'll prescribe the medication for the patient, and we can give her also, we will ask the mother if she have any question. We are ready to answer her questions. I think that's it.
That is the thing. So if you have to examine her, you will do that in the presence of the mother, and hysteroscopy you don't have to do. You will have to do vaginoscopy. So just going to place that. You will place that on the surface, and then you can see and treat. If you find anything, then you can do that. So What do you think? Why the kids are more likely to develop infections?
Because of the short perineum and because of the hygiene.
Yeah, hygiene is one thing, and then
No estrogen.
no
Low,
estrogen. That's why, yeah, no estrogen. So that's why pH is more. There is no, so they can't, metabolize this glycogen. So what will happen? The pH will be suitable for developing fungal infections.
fungal infection.
That is the point. Fungal infections, they can be there. Many things can be there. So basically, no estrogenification. So that's why the tissue is not like mature. So that is immature tissue. That is the which cannot prevent the infections. Okay.
Okay.
Thank you very much. And then you will give them information also. Okay. Why this thing is important? Because in each duty you are going to see one child who is coming with someone because she has some discharge. So first of all, you should remember that abuse is just one of the many causes. But this vaginal discharge in a young girl, it is distressing only, not only for her but for her parents also. So it is very important the way we are going to manage, and we have to give the information very carefully, because the further information, the information we are going to give, it is going to put the parents in distress. So especially if this is a case of sexual abuse, then it's very hard for the child, hard and harder for the parents, because they will get this feeling that they failed to protect the child like that. So first of all, you have to like take appropriate history from the girl and from her parents. This may provide important clues to the cause of the discharge. Information from the young girl, it may not be like very straightforward, because she's just a child, she's 6, she can tell you a few things and she cannot tell you. Most common cause, idiopathic. Then the second most common cause is this insertion of the foreign bodies, like the small toys, because, and especially if they see their mothers like they are using tampons or they are using these pads, so the children, they try to mimic these behaviors. There are case reports where this plasticine with which the children are making the toys, the shapes, they have to do that in the schoolwork. They will start inserting the plasticine, or they can keep inserting this toilet paper. So you have to be vigilant. Unless the children are sensible, you have to keep an eye on them, because it's not their fault. They are very immature. They will see anyone doing anything, they will just imitate that behavior. That is the point. If they have a foreign body, then the nature of discharge is very important. If they have a foreign body, then blood can be there, because it has hurt the tissue. There can be foul smelling discharge, it can be purulent also. So it should be determined. But if it is associated with itching, then the discharge, it may be related to the thread worms also, worm infestation. So from anus, they can go to the frontal part of the body also. And then if there is a sudden change in the bathing soap, underwear, especially the mother has changed from the cotton underwear to the synthetic one, or uh, dark colored dresses like that. So all of these, they can cause allergic reactions, or they can cause problems, and then the allergic reaction to the soap and these things should also be monitored. Then after this, with the consent, the physical examination should be done. Examination is very difficult in such children because they don't understand, and it can be very distressing. So this examination should be done by a doctor in the adolescent gynecology, as the doctor should be able to spot the signs of the sexual abuse. So you will have to take closed vaginal swabs for bacteriology, virology. We have to take them, and these may not be very reliable, because mainly they will be coming from the introitus. Then the presence of excoriations in the vulvoperineal region, it will tell you that it is good. It should raise the suspicion of sexual abuse. So if this is the case, then an expert must be notified to come and examine the child. You don't have to comment on that. This is job of the forensic expert, so you need to call them. That is also part of your job. You need to know that who should come and do what. So they need to take the pictures, swabs, everything, but only with the permission of the parents. And it will be distressing to them. So that it's very important that they should be taken to some area where nobody can listen to them. Their confidentiality is maintained, and then they are concerned about the way to call the social services or to involve police, all of these things. Then the social worker. Further investigations, what you have to do, abdominal ultrasound and X-ray. Abdominal X-ray, it will identify any radio-opaque foreign bodies in the vagina, although it is, if one is present, in case of discharge, it will need to be removal, but you will have to do that under GA. Ultrasound, it may have similarly, it will identify any foreign body, and then any procedure is necessary, then for removal, we have to do it under anesthesia. So it will allow the removal of any foreign body. However, this procedure, in the absence of the radiological support, we may miss the foreign bodies. How do we treat the discharge? The treatment options, they will obviously depend upon the identifiable cause. Where the foreign body has been identified, we need to remove it, and broad spectrum antibiotics are prescribed if there is superimposed infection, because the many bacteria, they are going to grow on the foreign body. Even when the children are putting these objects into their nose, into their ears, then the bacteria are going to develop on them. So she should be dewormed if that is the case, because the pinworm, they can also go to the vagina and they can cause discharge and they can cause severe itching in all epithelium. So where the treatment is simple, improvement in the hygiene, then we have to educate the parents that how they are going to wipe. Like they should not wipe the anus first and then wash the urethral area. They should wash urethral area first, then go backward and wash the this anal area. And unless the child has been properly toilet trained, she should not be left alone to wash herself. Maybe she's not doing that properly. That is the problem. Okay. Non-judgmental way, and you should be very sympathetic, very polite to the parents. And sometimes it will be only due to some allergic object, like maybe she is allergic to the nylon underwear she is wearing, so we need to remove that. And if she's having like contact dermatitis or something, then we have to seek the treatment for it, and we'll have to give them antihistamines. Then sexual abuse, that is a very important cause. You have to be very careful. You have to involve the forensic medicine people. So the gynecology and the pediatrician, forensic, they all should be there. And then further management can be according to the other things that they have found. Like the swabs, they will do the culture, they will take history from the child, and then other parts of the care, like they will have to trace the abuser and they will have to provide psychotherapy to the family, and they will need to educate and debrief the child also and the family also. Activate the child protective services also, because that is usually the someone who has access to the child. So in 80% cases you are going to find the family members, so you have to be very vigilant. But if they give you a case of abuse, it is a child or an adult, you don't have to comment on that yourself. You have to involve another clinician. If the family is resistant, then you cannot leave her as she is. Then you need to obtain the legal order for that child. You have to activate, and because a child is at risk, so you have to do everything to protect that child. But don't say straight away that this patient is undergoing abuse like that. Okay. So you can use vaginoscope, physical examination is fine, and sometimes they can come with injuries also. So then you should know that there is injury, then you will have to do the other workup like that. Then that is not your job. That is again the job of the forensic people to determine that if the hymen is there or not. Because in that case they will use the vaginoscope and they will use the colposcope also to see that the hymen is there or not, because as such they cannot comment, and then it can cause medical legal issues also like that. So these are the things. Sometimes they can give you the children who has like adhesion of the labia. Then you should know that it maybe this is congenital, or maybe this is because of some mild infections like that. And these infections, they will not be STIs. Okay? Then your patient is going to have labial adhesion. If they give you somebody who has labial fusion, then it's not your job to treat them. You just have to see that what is the cause, and then you have to involve a urogynecologist, because the problems in the genital area, they are going to cause problems in the renal area also, because they develop very close to each other. Okay, thank you.
This conference will now be recorded.
Okay, Dr. Priya, can you please
Okay.
start?
Okay, Dr.
This is 7 years old, present to the clinic with history of menstruating regularly for the past 4 months. So this briefly, possible causes of this girl problem. This is precocious puberty, so either from central causes or peripheral cause. Also, we have to rule out any other problem, but this is since 4 months. This is and definitely this is menstruation. Outline your initial steps in her management, starting from history, taking from the mother and the patient. After I introduce myself to the patient, just I will ask her when she starts having this problem. I will confirm her age, that she is 7 years old only. When she starts her menstruation, how many days, and is it regular, irregular? Does she have any secondary puberty, like breast develop, any abnormal hair growth, any hair growth starting from pubic area or underarm? Her height is increased like suddenly. Any history of headache or visual problem, any history of signs of diabetes, increased thirsty or polyuria, polydipsia, any history of like thyroid disease, that she has increased her weight. I will ask her also any history of inherited in the family from her sisters, or if they have any problem like 21 hydroxylase deficiency. I will ask her if she's having any history of headache, any history of milk expression from the breast, any history of abdominal pain, abdominal distension, or losing weight. This is mainly in the history. I will ask about her past medical and surgical history. Does she have any chronic illness? Surgical history, if she had any surgery before, any radiation exposure, any history of trauma or RTA. I will ask her about her continued social history, if she's studying, in which grade, and how is her performance at school. Family history, if the same problem happened in the family. Allergy and drugs, and history of blood transfusion. Then I will continue with the physical examination from vital signs, and then I will check her height and weight for BMI. I will check her general appearance, how she's looking, any abnormal hair growth, any change in her eyes, any acne she had. Then I will start from head examination, neck examination, any palpable masses, chest examination, also breast examination. I will see that she's having developed breast or not yet. I will check if she's having hair in the armpit. The physical examination should be in the presence of the mother. I forgot to say, the presence of the mother and staff nurse. Abdomen examination, I will see if abdomen is distended, that she had any hair growth reaching from the pubis to the umbilicus. Then by palpation, I will check for any ascites, any palpable masses felt. Then I will do just vaginal examination by inspection to see if there is hair growth or not. Any masses sometimes protruding from the vagina. Then I will continue with the investigation. So I will order for her according to the physical examination and history suspicious. From baseline investigation, CBC, check her hemoglobin, does she have any anemia, hemoglobin A1C, a thyroid function test, hormonal profile, FSH, LH, also prolactin. If I'm suspecting any tumors, I will order tumor marker, tumors in the ovary, I will order tumor marker. I will request MRI for the head, just to rule out any brain pathology. Also ultrasound for abdominal pelvic ultrasound.
Yes.
This is mostly in the investigation. Then assuming that no causes, also I will check for CA125. I will request 17 hydroxyprogesterone acetate, and for Cushing syndrome, just I will rule out any Cushing syndrome. So I will ask also for ACTH, and that's it.
Yeah.
Assuming that no cause is found, what will be your management be?
Yeah. So what are the
So
aims of therapy? Yeah.
aim of our management that just stop her menstruation if there is no, because sometimes it's only idiopathic. So if it is no cause, just we will stop her period until she reach 8 years or 9.
So how we can do
So
that? How we
by
can
giving her GnRH
Yeah.
GnRH agonist.
Yeah. That is the point. I'm going to give it to her, and then it is going to do modification of the hormones, of the native
Yes.
hormones. So then we can stop this one. And then what else you would like to give her? That is the basic treatment that we have to give it, and you will say that there are different purposes of giving this therapy, because you want her to achieve an adult height,
Yes.
and since there is a potential for abuse, so you want to protect her from that thing. Okay, that is one point. So then what else we have to do? Yeah, these are the main aims of the therapy, and till she has achieved this adult height. So what time you are going to stop this treatment?
Until she reached 8 or 9 years. 9 years, yeah.
9 years, or if you are giving low dose, you can give different modalities around the time of this having, once she has achieved her height. So what time the girls are going to achieve the adult height?
Adult height?
Usually they will achieve it just with like 1 year, 2 years before they will start having this menarche.
Menarche,
That is the time of maximum growth. So it can be given, period should be delayed, and then the treatment can be stopped at the time of just a few months before the expected time of this menarche. Because how you will know about that? That if she has other sisters or like the family members, they sisters who have that menarche or in the mother, they had at 11 years, so you can stop it just before that time. That is the point. Okay, and what else you will give her? You will give them a lot of information, and so you should mention that given information. So I will give her patient information leaflet, and I will take them through their course into the management of this condition like that. So thank you very much. So most likely diagnosis, precocious puberty, and why we are concerned, because it may be embarrassing for the children, because they are going among other children. But the other point is that they can have certain their growth will also stop. That is one thing, and then that is the main concern. Okay, and then there is potential for abuse also like that. Regarding the causes are basically two types: independent of the hormone, so peripheral one, and then dependent on the hormone or the central precocious puberty. Idiopathic most of the time, and then in others we can find the causes like there can be like familial variety can be there, or it may be due to intracranial lesions like encephalitis, abscesses, irradiation, hydrocephalus, tumors, and the traumas. Then gonadotrophin secreting tumors, autoimmune hypothyroidism, androgenital brain defect. Then there can be like there can be brain cysts like that, neurofibromas, even they can cause a huge list like that. And for most of these, there may be like unrelated symptoms. And the causes within the specific second group, these include congenital adrenal hormonal causes, and then congenital adrenal hyperplasia, enzyme deficiencies are there, Cushing syndrome, then McEwen-Albright syndrome, then exogenous estrogen ingestion, and the sex steroids creating tumors like that. So basically, the diagnosis is the diagnosis of exclusion. So after that, we can give the treatment. Her management, it should be approached with sufficient sensitivity and understanding. You have to tell the patients that it can occur. So first of all, you have to see that is this the natural sequence of events, like he can, maybe she has, we have to examine the child in the presence of the chaperone. Also, first we have to take a history, and then we will go and we will do the full examination. So we will see that this menstruation is associated with other changes like the thalarch, or maybe there is adrenarche, pubarch, everything is there or not. So information is obtained from the parents about the sequence of events like that we see in the first period, and associated symptoms of the hypothyroidism, that was the baby feeling, the girl feeling very tired, has she gained weight, has she become slow, has her performance in the school deteriorated. And then you will have to take a detailed physical history, like any history of trauma to the head, any history of having some viral infections involving the head like encephalitis, or symptoms of the endocrine disorders such as Cushing syndrome, like she has gained weight. And similarly, like for the hypothyroidism, a history of weight gain and slowing down, change in the behavior going towards depression. Other associated important factors should be included. These include infective encephalitis, headache, visual disturbance, and fracture of the skull. Maybe she has met some road accident. History of headaches, that can be suggestive. Then these will point towards the possible etiological factors. So careful history should be taken, asking about all of these conditions. After taking the history, we will have to do the examination in the presence of the chaperone with their permission, with permission of the parents, and we will have to look for certain other signs of precocious puberty. We have to inspect the skin for the development of cafe au lait spots, which will suggest that patient has neurofibromatosis. Other signs include enlarged thyroid gland, hydrocephalus, visual field abnormalities, then abdominal masses, and the abnormal ratio of the various long bones. Then investigations such as a thyroid function test, FSH, LH, we need to do these, prolactin, testosterone, estradiol, dehydroepiandrosterone, and we have to do screening for the Cushing syndrome, like we will give them stimulating dose of the dexamethasone suppression test is carried out. First with whatever they will do, like they will do the standard test to exclude Cushing syndrome. After that, if no further information is obtained, then we will have to do the MRI and CT scan of the brain. They will also be helpful in excluding intracranial lesions that may cause precocious puberty. And the bone age should be determined by an X-ray of the left breast, like that. So then we have to take a history of the other siblings also, that at what time they had menarche and how it is different. And mostly, there can be like constitutional delay. That's why important to ask about the other causes. Then assuming that no cause is found, so what will happen when we take the bone age? If the bone age is more than the chronological age, then what will you think about? Think about it. Now, if the bone age is more than the chronological age, then your patient is going to have central precocious or the peripheral precocious puberty.
Central, like acromegaly.
Yeah, that is one thing. And if the bone age is, and the other end of the spectrum can be when there is constitutional delay, then the bone age will be less than the constitutional age. That is also one thing. But so then that no treatment has been found, so this is idiopathic. So where the cause is constitutional, like no obvious cause is found, the treatment of choice is gonadotropin releasing hormone analogs. And whenever you are giving a medicine, you should know how it is going to act, because these are going to inhibit the pituitary function and therefore they will suppress ovarian activity. Exogenous estrogens, they should be avoided as these are responsible for the premature closure of the epiphysis. They can ask you this question, why you will, so can you give her COC please? Will you like to give her this estrogen? You will say no. Why? Because it is going to close the epiphysis, so the adult height will not be achieved. Cyproterone acetate, it has also been used in some, but it is associated with some success. And the advantage of this using cyprotenone is that the anterior pituitary is not completely suppressed. And medroxyprogesterone acetate, it has also been tried, but it doesn't appear to be associated with much success, other treatment options. And the implications of this condition must also be addressed. If the girl is ovulating, then the possibility of the pregnancy, if she is sexually exposed, it must be considered. And sensitive counseling, it must be offered in this regard. And the second consequence of precocious puberty is premature closure of the epiphysis. And although the girl may initially be tall for her age, but ultimately, like maybe she has an accelerated growth velocity now, but when you will compare her at that time of puberty, then her height will be shorter than her other friends. So whatever treatment, whatever treatment the girl is offered, it must be accompanied by adequate psychological support. And this will also depend upon her age and her needs. And in other words, psychotherapy, it must be tailored to the needs of the patient. That is one thing. You have to warn the patient according to the possibility of abuse also. Then regarding abuse, I wanted to tell you another thing, that now the emphasis has shifted from the this hymen to other things. First of all, they see that the hymen, it is as you know that there are so many different types of hymen, like then there are so many different types of abnormality, like if the growth is not appropriate like that. Then second thing is that this is an elastic tissue, so maybe even without rupture gate, it can be distended. So now the more and more experts say that we have to, if you are suspecting something, then you have to take interview of the child in a very sensitive manner, and we have to rely on the story that the child is telling. Second thing is that if you have to use some look at the hymen, you should use vaginoscope or you should use colposcope, because even in the clinical practice, don't rely on your own judgment, and it can lead to litigation. Then when you are examining an adult woman, you want to look at the hymen or like an inspection of the vulva, you are putting hands on the fingers, two fingers you are putting on the posterior portion and you are separating them. When you have to examine the child, you have to put two fingers on the anterior part of the labia, not the posterior part. Okay? Then you are going to separate from there so that you can see that if there is any abnormality. If you have to examine for the fluids and the other things, then like Dr. Aisha said, you have to do the PR. Why PR? Because PR is well tolerated. Why it is so? Because they are defecating also, so that's why they are used to this thing. And of course, you are not going to do that without anesthesia. That is the point. So if the girl has been undergoing this abuse, your job is just to provide the treatment, and rest of the things and the medical legal and that stuff, that is job of the forensic expert. If forensic expert is not given, like he is not available, then you will call another gynecologist, and then you are going to make her management plan. So okay, thank you. So who will do the next?
This conference will now be recorded.
Okay, can you please start?
Okay, Dr. Rashid, this is 37 years old woman present with you with a regular and heavy period. After the reason and investigation will be taken on her. Before I will, after I introduce myself to the patient, I will ask her some brief question, focus history about her complaint. I will focus on the
Hello, can't hear you. Yeah.
I think
menstrual history, the Egyptian menarche, regularity for how many interval, how many days, about the flow rate, bad sheet, any symptom, any post. I will ask her.
Yeah.
Yes.
Yeah, no problem. Please continue. I think your internet is.
Yes.
Yeah.
Okay.
You please
Okay.
continue talking. Yeah. Okay.
Okay.
What will you do then?
Okay. And then Then I will ask about any anemia symptom. She has any medical disease, thyroid, or she is investigated before, or any receive any treatment, any ultrasound, or seek any medical advice, any bleeding disorder on her family. Then I will, after you take history, detailed history of medical, surgical, and menstrual history, I will, after investigation, I will examine her general examination and then local examination by speculum to see if there is any local causes. I will ask her even if she is done pap smear done for her or not. I will take her pap smear and to see any local causes. Then I will investigate her by lab investigation and radiology. I will start with the CBC to rule out if there is any anemia, and the thyroid function test. If there is any disturbance in the thyroid to regulate her thyroid hormone, and BT for coagulation and coagulation profile. And we can order for her the hormonal FSH, LH, estrogen, and prolactin. And radiology, I will do for her ultrasound, pelvic ultrasound, to see any lesion, intrauterine lesion, any cervical lesion, any fibroid, and there is any suspicion. I will about the endometrial thickness. I will take the endometrial biopsy, or maybe need for hysteroscopy. This is about the investigation.
Okay. So what treatment options will be available to her? She doesn't want hysterectomy.
We have the medical treatment. If there is no, and also there is conservative treatment. Maybe she needs only cyclic combined OCBs to regulate her period. And if there is, if she is benefit and this regulate her period, and maybe you find any ultrasound, there is any small fibroid, maybe this is for conservative treatment and follow her by ultrasound. If there is continuous bleeding and after OCB, we can give her non-steroidal anti-inflammatory drugs to reduce her pain and the period. Antifibrolytic, we can give her tranexamic acid to take during the period if there is no contraindication about use of the OCBs or tranexamic acid. And we offer her about the Marina, and this is as used as contraception for a long time. This will be reduce the bleeding around 80%. I will explain to her about any complication with the IUCD. Maybe she found any irregular vaginal bleeding during the first insertion, and then will be maybe tolerated. Or we go for GnRH agonist. After explain to her the side effect, and then the surgery, we will offer her surgery. We have the if there is fibroid, we will go for fibroectomy, myomectomy, or uterine artery embolization. I will explain to her the procedure, side effect, and side effect or the complication during the procedure, or endometrial ablation or resection.
Okay.
And finally, the hysterectomy, but patient exclude the hysterectomy.
Yeah, so for how long? So for her, what else you would like to tell her about the medical treatment? Can we combine medical treatments?
Yes. We can combine with the OCBs. We could give her the cyclic progesterone, bromolet, and during the period for cyclic, use it for cyclic. And
so if the medical treatment has, sorry, yeah, please continue.
This is about the cyclical OCBs and bromolet, and I will explain to her the effect of the bleeding, maybe decrease around 40%, and the side effect with the breakthrough bleeding.
So let's say that she didn't respond to combined medical treatment also. So hysterectomy is the last thing. Can we offer her something before going for the hysterectomy? Because hysterectomy doesn't count, but what about other procedures?
Endometrial,
yeah.
uterine artery embolization and ablation, endometrial ablation.
Okay. So
if there's correlate her family, we will go for hysterectomy. Or suspicion of the cancer, I will offer her the hysterectomy.
So what are the complications of uterine artery embolization?
Nausea, vomiting, fever, maybe persistent continuous vaginal bleeding, and hemorrhage, infection, and hematoma during the procedure, and maybe she will enter for infertility and premature ovarian failure.
Okay. What about post-embolization syndrome, when she can have develop this complication?
Patient continuously have abdominal pain with fever, nausea, vomiting, and
Okay, that is one thing. So what benefits she can have if she opts for endometrial ablation? What type of procedure is that?
this is there is risk of the uterine perforation with endometrial ablation, and patient maybe go for amenorrhea, I think.
Yeah, she can have dysmenorrhea or she can become amenorrheic like that.
Amenorrhea.
These are the problems. So once you have consulted her about all treatment options, what will be your next step?
After I explain to her, I will give her a follow-up, maybe follow-up if she want to think and to come back to me to decide what she want.
Okay. So she is having like heavy periods, so you will like to do the CBC. So at least with the CBC, she will come back, and then you will give her treatment, and then she needs review. So you will have to tell her that if the symptoms improve well and good, then at least give her 1 month, and then after that you should review her treatment. But still she is having any problem, then we can go for other things like that. Okay, thank you. So here, yeah, anything else if it comes to your mind, you can always tell later also, no problem at all like that. So this patient, like she has been having regular, she's 37 and she has been having regular heavy periods. The reasons outlined with reasons the investigation you will like to undertake on her. So history has been taken, take history, confirm the biodata, everything. And then physical examination, you have to look for the general physical examination from head to toe because you want to look for anemia and the pallor. And you also have to look for other causes like maybe she has thyroid masses. And then we have to do the abdominal examination. Maybe she's having some abdominal masses, some pelvic masses like that. So with the consent of the patient, now if she's having like problem like this, we need to see that she doesn't have any structural abnormalities because she's 37, right? If they give you somebody like who is very young and she just had this menarche like 1 or 2 years ago, then you know that automatically that this woman has luteal phase defect. Why? Because her hypothalamic pituitary ovarian axis is still developing, right? But this one, 37, we have to confirm that is she nulliparous, she has or she has any children like that. So the causes of menorrhagia in the in the mature women, like who had a normal pattern before and now they have become abnormal, you have to think about the structural abnormalities. So you need to take a detailed history. After that, you are going to do the physical examination. History briefly, that how were the periods before and how they have changed now, because change is just one thing, but in which way they have changed. Like have they become irregular or the length is normal? And has she had these cervical smears or not? These things are important to exclude the local causes of the bleeding also. Any history of intermenstrual bleeds, anything. So you will say that I would like to ask her a few questions in the history, and then you should mention these points. What is the pattern of bleeding? You need to establish that. So structural, you have looked for the general you have done general physical examination, and then you have done the local examination with her consent in the presence of the chaperone. And you have to document everything. And if you can help by making diagrams, you should make them, and you should write your findings very clearly so that this woman will not be seen unnecessarily later by another person. Regarding the investigations, this full blood counts, that is the most important in the basic info to look for. Whenever you will mention any investigation, you have to say why, because you want to exclude any anemia. Then if she has been having like severe bleeds, and she's anemic now, so maybe she will need transfusion or she will need oral therapy. That is one thing. Other investigations should be taken that if she has, not without symptoms, if the patient has other symptoms of hyperthyroidism, then we need to do the thyroid function test. Then after that, so after CBC, after thyroid function test, you need to do the coagulation profiles, because you want to look at her, this one, that she has been having regular periods before and this is some new change. So because if the patient has been having some bleeding disorders, hereditary bleeding disorders, then she should be menorrhagic right from the start. 37 is too late to present first time with this complaint. Then a pelvic ultrasound should be performed if the uterus is palpable or there is an adnexal mass palpable per abdomen. Then after that, like this, the GP or the people in the PACC, they have given her treatment and it has failed, like as per her story. So what you will like to do, you will like to do you will do simple ultrasound, then you can do this saline infusion. Sonohistography is not routinely indicated because it is not going to help in the diagnosis of, not going to establish any specific cause. So you don't have to offer it. Hysteroscopy and endometrial biopsy. That is the standard of new standard of care, like for the last 3 years, that we need to take the biopsy and we need to do hysteroscopy to look for any structural abnormalities, and then we need to take the biopsy. So these things, like if we have no other information, then we need to carry out these procedures. At hysteroscopy, endometrial biopsy should be performed. There is suspicion of hyperplasia or malignancy. Regarding the outline treatment, you will say, I will explain to her full range of treatments, like like we will start with the conservative management. No role of conservative management if the patient is having symptomatic bleeding. So then the second option is to give them COCPs. That is the first medical therapeutic option, and because it is cheap, it is efficacious, and additional benefit of the contraception if she needs. However, in view of the woman's present age, it may not be very suitable, especially if she is a smoker, she is overweight, or she has any risk factors for the VTE. Additional disadvantages that to take the pill regularly, so the compliance is going to be poor. Then the first line treatment. What are the first line treatments if your patient has bleeding? Any one of you?
You mean like non-steroidal or what do you call it? Tranexamic acid?
Yeah, all of these things, like anti-fibrinolytic agents, all of these are like the first NSAIDs, not COCPs, the NSAIDs.
Doctor, can we divide them to hormonal and non-hormonal?
Yes, of course you can.
I think it's
No problem with that one. Because you know that is also easy. Basically, you know, you have to say that which is the first line treatment. So what else we can give them?
OCBs.
Yeah, OCPs and
Methylamic acid, tranexamic acid, OCBs, intrauterine device, the Mirena, Depo-Provera.
Did you give Depo-Provera?
No, it will cause increase. Sorry. Depo-Provera will increase the.
What else we give? We give norethistine, which is a common primordial. Like that.
We can give.
You can divide into the hormonal, non-hormonals. That is one way of classifying, and then the hormonals, like they are further divided into, like you are going to give them locally or you are going to give them systematically. So you can follow any pattern, but you should know that which is the first line that we what should be offered in preference to the others. Like that. It is one point. Yes, dear.
We cannot give progesterone.
Progesterone, only this norethistone, that is a progesterone. This one. Yeah. You can you know, Depo-Provera we don't give in the acute cases. Why? Because it will take some time. Unless an effective level of the drug has been achieved, we cannot give anything. Methnic acid,
Okay.
so that is not going to be like very beneficial. Actually, if you will follow the guideline, if your patient has acute bleeding, then you all know that what should be the first line. Acute episode of hemorrhage, you have to give conjugated estrogen, right? Then
And
you have
intravenous estrogen is the first line if to
intravenous, yeah.
control heavy bleeding.
Yeah, you have to give 25 mg IV. This one, estrogen in the absence of, but you should know the cause of the bleeding. If that is suspicious, you cannot. But this one, if he's like just pouring blood, then you will give her conjugated estrogen, IV estrogen, that is first line. Otherwise, you have to go for the established treatments. Any treatment you are going to mention, you have to mention, you are required to mention what is the mode of action of that drug, how much reduction in her symptom, like how much bleeding is going to decrease, and then how is that is sustainable, like that is going to be permanent method, because we have to give her therapy at least for 3 to 6 months, like that. That is one thing. Okay, so the first line treatment, second line, and the third line treatments. Okay, after that, these are the medical treatments, and once the medical treatments they fail, then you have to go for surgical treatment. So you have to see that this patient has any risk factor for any other thing, otherwise you are going to give them tranexamic acid. Then you should remember that one significant side effect is that when it is given in very high dose, it can cause VTE, so you need to exclude VTE risk factor for the patients. So mefenamic acid and the tranexamic acid is very effective, like 70 to 80% patients, they are going to have reduced vaginal bleeding. If that is not acceptable or the patient has contraindication, then you need to give them NSAIDs. Okay, NSAIDs at least 50 to 70% effective. That is the point. If that is not acceptable, then we can give other prostaglandin synthetase inhibitors, such as we can give other things, like you can give brufen, voltaren, all of these things, but you will say Ponstan, but you will say that you are going to give prostaglandin synthase inhibitors. Then levonorgestrel, that is an option which is advantageous for 5 years, and the other things have come into play now. This levocert, that is also, it has been licensed for 5 years in cases of heavy bleeding. Okay, it can also be given like that. So it also contains progesterone, but this is also an intrauterine device. Only I think 2 years ago has been licensed for use if the patient has heavy menstrual bleeding. So it is going, if it reduces the menstrual blood loss by 80% within 6 months of insertion, and then this is the Mirena, and it is expensive, but even if the patient is able to use it for at least 1 year, then it is going to be cost effective. And the benefit is that this intrauterine device is going to be effective even if the patient has history of PID, so still she can use it for contraception and then to control her bleeding, like that. Other things, like if the patient is not benefiting from them or she declines, then that is the option of the anti-estrogen or gonadotropin releasing hormones. They can also be given. They can be given through different routes, but mostly we are giving them as injectables. Then depot preparations, they are also available and can be given. And the side effect is that the cons are that they expensive and associated with menopausal symptoms. So we need to consult the patient about the side effects, and then we can start it. And if we will continue it for more than 6 months, it can cause osteopenia unless combined with the add-back therapy. Cyclical progesterones in the form of this pyrimethamine from day 5 to 26 of the cycle, they have also been proven to be very helpful. So that is the one point that it usually causes. That is only just that the trials have shown that it is going to cause less bleeding and patient is going to have improved quality of life. Regarding the side effects, you should remember that it can also cause breakthrough bleeding. It can cause mastalgia, breast tenderness, and the mood swings. And it has to be taken, if they are taking in the form of tabs, the cyclical progesterones, they have to take on the daily basis. And then if they miss some tab, then they're going to have the side effect. So everything should be given. and the source of bleeding should be diagnosed like that. Surgical options include ablation of the endometrium, and for this, the second generation devices, they are recommended. And the techniques, they require skill, and they also need special equipment. If we have the expertise, then we will offer it to her. Most are undertaken in the hospitals, and they can be done as a day cases, and we should be able to recognize the complications, and we should know that the treatment is appropriate or not. Then you will say that complications include persistent vaginal discharge, post, then you know this, that is one thing. One thing was endometrial ablation. Then another thing is interventional radiology, like we can offer the uterine artery embolization. It has certain side effects, like first of all, there can be non-target embolization, like we have missed the actual blood vessel. Then problems can occur during the procedure, like patient can have bleeding, and then immediately after the early complications are that she can develop infection, bleeding, pain. Then the late complications, these include that she can develop vaginal discharge and post-embolization syndrome. But what is post-embolization syndrome? She was justified in telling us, Mariam, that patient can have pain, nausea, vomiting, fever, and it will not require hospitalization. And less commonly, patient will need further therapies. Then she can have premature ovarian failure, and she can have hematoma formation. The risk of having premature ovarian failure, if she is younger than 40, then her chance is going to be just less than 1%, that she will have premature ovarian insufficiency. But if her age is like over as 45, then her chance of having premature ovarian insufficiency will increase. It will be doubled like that. That is the point. Okay. So then you have to counsel them about all the side effects and complications, and then you will say that I will involve her in decision making, and then I will document everything as to her, as aid to her management.
This conference will now be recorded.
Can you start, please?
Okay, this patient is 31 years old, para 2+1 with secondary amenorrhea. Pelvic examination was normal. What additional useful information will you obtain from the patient about her complaint? And outline investigation you will undertake on her, and how will you treat her if the cause is found to be non-endocrinological. Okay, I will start with introducing myself to the patient and ask her permission to take history and examination. Now I will start with what's her complaint now. She is secondary amenorrhea. For how long is this amenorrhea, and for how long is she associated with any no pain at all, no bleeding, no dyspareunia, no any pelvic pain. Then I will go for the menstrual history. How was her menstruation before? If she was regular, irregular? What about her contraception before? What is about her STDs and Pap smear? I will ask also about her medical history. If she has diabetes, hypertension, any thyroid dysfunction before, any surgery. Then I will ask also about there is hirsutism, there is
Yeah.
Then I will start the examination with I will check signs of hyperandrogenism. I will check obesity. I will check BMI, her vitals, pulse, blood pressure, temperature. I will check her abdominal examination, any abdominal masses or tenderness. Then I will go for the pelvic examination. I will by inspection any signs of atrophy. Then I will go also with I will ask for permission to take swabs, or if not taken a long time, Pap investigation. The investigation, I will start with beta HCG quantitative. Then I will go for, if it is negative, I will go for the hormonal profile, FSH, LH, T3, T4, TSH, البرولاكتين, serum testosterone, free androgen index. Then I will deal according to the finding of the also I can do pelvic ultrasound for her, just to check no abdominal masses, no any abnormality in the uterus and the adnexa. Then I will go for the management according to the cause. If there is only يعني البيتا HCG quantitative are negative and the just serum testosterone, or there is also associated hyperandrogenism, I will deal it at the PCO and I will handle it. I will start with conservative management, like diet and obesity control, exercise. If FSH and are high, maybe it will be repeated after 1 or 2 months to check it is the premature ovarian insufficiency or no. If the thyroid function, if the thyroid are high or any abnormality in the thyroid function, I have to deal with it, refer her into endocrinology and to control.
Yeah. So you can just
I think I think
Yeah.
that's it. But what is non-endocrinological cause?
So how will you treat her if the cause is found to be non-endocrinological, like it is not because of hormones? She has secondary amenorrhea, but the fault is not in her hormones. Can you think of any cause when the hormones were not disturbed and still a woman can have amenorrhea?
Pregnancy.
Yeah.
Doctora, it will depend on the onset of her amenorrhea.
Yeah. The circumstances, how it started.
Did her amenorrhea start from last delivery or not?
Childbirth.
Because if you're saying non-hormonal, I'm not sure if you're inclining that it's like Asherman or not.
Can be Asherman, because myself I have not read the key. So we are just thinking about the possibilities that what could be there. So maybe Asherman can be there, or maybe
lactational.
Yeah, it can be lactational. So all of these things. Maybe she is
طيب.
pregnant again. So the first
Maybe
test
pregnant now.
So the first test that a patient comes to you and she's in the reproductive age group, what will you like to do for her? Hormones are the second thing. First thing is we have to see that she's not pregnant like that.
I ask it first. I tell first we have to do a pregnancy test.
Yeah. So I didn't tell you that what is the result. That is the point. So what else can be the cause? Yeah, you're right. Don't feel bad. Any
exercise,
yeah,
extra exercise, like strenuous exercise she is doing.
And she's taking any therapy, maybe secondary to the
Stress.
therapies.
Stress.
So many things can be there, like that. Hyperprolactinemia can be there. So many things can be there. So let's go for it, okay? Don't worry. Everything you have mentioned, actually, when we talk about the secondary amenorrhea or the primary amenorrhea, for primary amenorrhea, the causes are still limited. But for the secondary amenorrhea, any pathology, in the endocrinology, in the reproductive endocrinology, things can go wrong at many places, okay? That is the point. So the detailed history is more important. So if the purpose of bringing in such stations is that if you have a station like this that they're asking you the investigation, so you should say I would like to take a brief information from her that when did it start, because they're telling you it's secondary amenorrhea. For how long she has been having, we don't know. V was done and things were found to be normal. So what additional useful information you will obtain? So the history taking, that is the most important part, detailed history. Pregnancy should be included, should be excluded. Any is she having any symptoms of pregnancy? Sexual history including contraception, these are important. History of weight loss either induced by exercise or anorexia. It will also suggest a hypothalamic cause. Similarly, you have to take information about the stress and a sudden change in her circumstances that could also lead to hypothalamic causes. Hyperprolactinemia, it may present with whitish milkish discharge from the breast or only with the amenorrhea. An inquiry should be made about if she has been taking any drugs which can cause hyperprolactinemia, like maybe she was taking like ralofia alkaloids, but ask about the medicines first. Methyl dopa, methyl dopa, antipsychotic drugs, phenothiazines, and H2 receptor antagonists, they all may cause amenorrhea. And has she been using this Depo-Provera for? First, you will ask, the first question will be that for how long she has been having it like that. And then is she using any contraception, or what was the time when she had this second child? Because there are 2+1. So when was the last delivery? That is important to know. Symptoms such as, and has she been taking this Depo and then Danazol for any reason? Then symptoms such as hirsutism, acne, weight gain, voice changes, they will be suggestive of PCOS or an adrenal tumor. As simple as that thing can be there. If she has developed these symptoms gradually, then think about the ovarian causes. If she has developed these suddenly, then we will ask about the adrenal etiology. If she has had any surgical treatment of the miscarriage or management of the postpartum hemorrhage, they told you what? Para 2+1. Did she lose a baby? She had this miscarriage. Were the POCs removed by surgery? We have no idea. Or did she deliver the baby and after that she went into PPH? Did she go for any termination of the pregnancy, or she had any myomectomy? Then you have, I mean, any procedure, any intervention was done, then you have to think about the Escherman syndrome. That is one thing, because this is secondary. Had it been primary, then we would have thought about the obstruction at the level of the hymen, or then transverse vaginal septum, because if there is longitudinal septum, that is not going to obstruct the flow. So then finally, symptoms of thyroid dysfunction and Cushing syndrome, they should be excluded. What the symptoms, if she is having any? Then the investigations. So investigations, they must aim to exclude possible causes and to reach a definite diagnosis. So these will include pregnancy test first of all, followed by hormone profile like FSH, LH, prolactin, testosterone, sex hormone binding globulin, and the androstenedione, TSH, and free T4. Other investigations to be performed, they will depend upon and suspected cause of amenorrhea, like hysteroscopy, hysterosalpingography to diagnose Escherman syndrome, and now we can do the saline infusion histography also. Then ultrasound and hysteroscopy also. Hysteroscopy we already said. Ultrasound scan of the pelvis to exclude PCOS, then a CT scan of the brain if a tumor is the suspected cause with the karyotype, especially that if the patient is having premature menopause is suspected. If TB is suspected so as a possible cause, then that tuberculin test should be done, or you will screen the patient by asking that from which area she has come, because in Africa and Asia still it is a common, not common, like, but it is a possible etiology. If the patient has history of exposure to someone who was having this TB, then the PPD test was done or not done. That is going to be the basic test. Positive, send her to the chest disease specialist. They can do the X-rays and other things, and then we will think about the if that is negative, then you will think about the primary genital tract TB. Then how you will treat her if the cause is found to be non-endocrinological. Then the most likely cause is Escherman syndrome, although other causes such as TB and the premature menopause, they must be considered a differential diagnosis. Another point which I didn't ask in the start is that you should ask that when was the last baby born, and then was she able to breastfeed or not? Because if she says that she couldn't establish this breastfeeding, then you have to think about Sheehan syndrome. There was pituitary apoplexis due to hypovolemic shock, something. And that's why she was unable to feed the baby. But if she was able to feed her baby, then you have to think about the local causes. Like maybe she underwent some surgical procedure or infection and she has developed adhesions. That is the point. So if the TB or the premature ovarian insufficiency, they have been excluded, you have to look for the Escherman syndrome. And what we have to do, we have to do the hysteroscopic examination and division of the adhesions, and then insertion of a intrauterine device to prevent formation, reformation. That they will not, like you can put this balloon, you can put other devices so that the walls, they will not be approximated. Otherwise, they will block the cavity again. Adhesiolysis should be done, and then we, after this, keeping them separate, we have to give estrogen stimulation for regeneration of the endometrium from the glands. And this treatment is not very successful, and if the patient doesn't want any more children, then reassurance is needed. Then if she denies pregnancy, then appropriate counseling will be required. Unless she resumes normal menstruation, the chances are slim that she is pregnant, that she has any other problem. In addition, the risks of miscarriage, premature labor, placenta accreta, percreta, they are high with the subsequent pregnancy, like when you have removed the adhesions. Then for the TB, if the patient is found to have this genital tract TB, the chance is very rare, like 1 in a million. In that case, we will refer her to the chest disease specialist so that he can give them anti-tuberculous drugs like that. And if you have done the FSH, serum hormone, and you have found it to be higher than 35, then you will repeat that, and no other cause is found, then you will have to repeat this level after 4 to 6 weeks, and still it is found to be higher, then you will make a diagnosis of premature ovarian insufficiency, and so then you will have to give her HRT. Other causes of premature ovarian insufficiency, first of all, this is going to be idiopathic. No cause is found. Then those who are symptoms where the cause is found, then you should know that it can be due to autoimmune disorders. It can be due to karyotypic abnormality, like if it is, I think, because 31 is young, right? So if she is having it, so you can think about the Turner's mosaic, because in that the patient, but she will not be diagnosed with Turner mosaic in her 30s. She will be diagnosed in the early 20s. That is one thing. And then for such patients, if the premature ovarian insufficiency is the treatment, then you will have to give them HRT till the age of natural menopause. Then you have to pay attention to their bone health, and then you will have to offer them CBT also. So focus on bone health when there is premature ovarian insufficiency, and then behavioral CBT also. Why? Because this patient will be under tremendous stress, so you need to do that one, and then give them patient information leaflet, and then tell them about sport groups. So the treatment, basically, it will depend upon the cause, like that. Okay, thank you very much.
This
Can we start,
conference will
please?
now be recorded.
So, how will we manage a patient with 47 years old presented with severe premenstrual syndrome? So we'll start with the history first. We'll start with we'll confirm the age, the gravity counts, and LFPs. What is the last LFP? And then we'll ask about menstrual cycle, is it regular or irregular? For how long? How many days? What is the cycle length? If she's having menorrhagia, intermenstrual bleeding, or intermenstrual bleeding, postcoital bleeding, if she have any PID, STDs, and she did pap smear or no. I'll ask about her premenstrual syndrome. If she's having, what's bothered her the most? Is it if she's having headache, bloating, anxieties, depression, sleep disturbed, edema, abdominal pain. So we confirm what's bothered her the most. And we'll ask her about when does this premenstrual syndrome happen? It's the last week or few days for the period, and when it's end after the period immediately, or it takes some time. And then I asked her about she's having other symptoms like food craving, tension, um, mood swing. If you have prevalent pain, breast tenderness, fatigue, how this affects her life, and does it affect her work, social life or not. Um, we asked her about the previous obstetrical history, and parity, and how many children she have, if she's uh, infertile or not, and how many children, uh, mode of delivery, vaginal, cesarean, and we asked about the social history, if she's smoking, taking alcohol, illicit drug, and if she's taking a lot of caffeine, is she's doing exercise or not, does she have any stress in her life or not. Then asked about the medication, is she taking any medications, blood transfusion and allergy, and possible history. Then we can go for examination briefly. Do you want to take the examination or go to the management first?
Okay. So
You
if
want
she,
to
yeah,
you
so
want
what would be your management? Yeah, please.
yeah. So in management is depend on the cause. Depend on the management depend on the what's better for the most. We can start with lifestyle modification. We'll tell the patient to do exercise, avoid stress, and decrease the fat intake, decrease the uh, salt intake, um, uh, decrease her weight. She's obese, and yeah, stress management. And then we can go for medication like medications like non-steroidal anti-inflammatory. If the pain is bothering her the most, we can start with OCPs. We can start with according to the cause of what's bothering her the most. If it is the depression and sleep disturbance, we can go with SSRI. We can go with if if it's failed, we can go with inhibiting the ovulation, like inhibiting the period GnRH agonist. Um, which is GnRH agonist, progesterone, OCPs. But the OCP, if she has breast tenderness, we might avoid it. So we might depend on the course actually, on the symptom, whatever it is.
So if the patient, if the patient asks you that she would like to try some herbal medicines from her PMS, what will be your answer? She says that she has found that she likes to try some over-the-counter herbal medications for her PMS. How you will counsel her?
We'll tell her that there is some herbal approved efficacy, but there is no approved safety. They didn't approve safety, so she might try it.
Yeah, basically, people are buying many things, but we know nothing about their efficacy like that. That is one. Right? That they have, these things have not been validated, so we can't comment on them, because every now and then they will bring this ginseng, they will bring this primrose oil, they will bring like recently there was a lot of research on another herb. The name of that herb was very weird, Jin Kian Ping. So you should say that these have not been validated for this purpose, and we have no idea. Maybe they are good, but we have no data on the safety of these drugs. So I'll advise you to go for the standard treatments like that. Okay, that is one thing. So if she asked you that what is the chance that she will recover?
The chance, the number you
Is
mean?
good. Yeah, with sportive therapy, 50 to 60% of the women, they will feel much better like that. That is one thing. But so when you will like to involve the psychiatrist in her care?
If she have severe symptom,
If she has mood symptoms, depends. Yeah. If she has severe mood symptoms, then you are going to involve the psychiatrist also like that. So what type of therapy should be offered to them? If they are having like too much nervousness and they are having more accidents around house and work, then what
SSRI, selective symptom.
SSRIs and cognitive behavioral therapy like that. So if she fails to respond to all treatments, what will you like to give her now?
GnRH,
Okay, GnRH.
continuous SCP.
Yeah, or you can give her continuous SSRIs can be given, and you will give the newer generation. So you gave her all treatment modalities. She didn't respond to anyone, and she wants to have definite treatment. What will you give her now? What will be your plan for her now? Is
Gen
TAPSO going to help her?
is what?
Total abdominal hysterectomy and bilateral salpingo-oophorectomy, is it going to be helpful?
Yes, it will help, but it will help, but the symptom of the
But can she still have symptoms after having this extensive surgery?
she
Is she
might
going
have.
to have the symptoms still?
She might have.
Yeah, she's going to have. And what will be the main disadvantage for her? Like she is 37 and she has lost her ovaries and the womb. So she will
Yeah,
have surgical menopause.
yeah.
So then she will
Osteoporosis,
have,
cardiovascular disease, stroke, all the complication of lower estrogen. There is a
yeah,
risk of cancer.
yeah, these are the things. So basically the treatment is very complex, and the PMS, if you have to define PMS, what will you like to tell me? Is it a single condition or this is a syndrome?
It's a syndrome.
Syndrome, and it can be of like many varieties.
Yeah,
Like, yeah, you can say that it is divided into many disorders, and according to the sensitivity, according to the extent and then nature of the symptoms. Okay, you don't have to comment on them, because if the patient is having like dysmorphic syndrome, they are not happy with their appearance, that is also a type of PMS like that. So PMS, that is the thing. So how common is this PMS?
I do.
Quite common, like maybe 40 to 50% payment they are having it, but the severe one you are going to see in only 5 to 8% like that. So, and then you should know that it is more common at the extremes of ages, like very young and very old like that. And why? So anything else you would like to tell her? You will just give her PIL, put her in sport group, and tell them that they should go for regular exercise, diet therapy, all of these things, because we want to address all important issues like that. And the treatment options, like you have said, that numerous options. So remember, as a general rule in the medicine, if you have more and more treatment options for a single condition, what does it tell you? That none of them has been found to be very effective. That's why it can be exceptions, but mostly if you have like many drugs for the same disorder, then you should know that we don't know about the single most effective treatment. And besides that, treatment is not going to be the same for everyone. Like, That is one thing. Okay, everyone is going to behave in a different way. So your patient is going to present in a number of ways. So this is a set of disorders, many disorders, and the patient can have like different varying degrees of troubles in her life like that. She can have psychological symptoms, she can have physical symptoms like that. So the patient has come to you, you will confirm the diagnosis, you will see that has she kept daily record of the symptoms or not. It should be done prospectively. Why not retrospectively? Because we tend to exaggerate the signs and symptoms. So that is one thing. And then the therapeutic trial with the GnRH analogs, it may be more precise and effective in some cases where the symptom diary is not helping, then we can give them GnRH analogs because it will cause decrease in the ovarian activity, and then the symptoms they should improve. Once the diagnosis is confirmed, then the treatment management options. We need a multidisciplinary team. Who should be in the team? Gynecologist, psychologist, or psychiatrist, which is sometimes their help is very important. Various treatment options for PMS. It has a high placebo effect. Placebo empty bullet, like we are giving them something which is not effective, doesn't contain any active drug. So in fact, placebo effect, it has been reported in more than 90% in some studies. And the treatment of choice will be influenced by the patient's desire for contraception or contraindications to the treatment. That is one thing. So in the absence of contraindications, the COCPs, they will be the drug of first choice, and it suppresses ovulation, and it may still be associated with symptoms of PMS. Why? Because of the progesterogenic effect like that. The COCPs, they may completely relieve the symptoms and limit them to 1 to 2 days. And premenstrually, they can be given, patient can have, or it may be ineffective. The second therapeutic option will be progesterone only. First one, COCP. Second one, we should give progesterone only. So the time it can be taken in the form of oral tabs, or it can be given as pastilles as suitable for the patient. Then we can give them like 3 monthly or 8 weekly injections. They can also be given, but their exact role is unclear. That is one thing. Then the GnRH analogs, they are probably the most effective medical options for the treatment of PMS. And then they are going to suppress the hormonal activity by down regulating the pituitary glands. And in this patient, they may not only alleviate her symptoms, but they can provide her support for the contraception also. And then we should give, like, if we are planning to give it for more than 6 months, then we have to more than 3 months, then we need to add the add back therapy if we are planning to give it for 6 months or beyond that. And the first line, they contain SSRIs, and among the SSRIs also escitalopram. The newer SSRIs, they have been found to be more active. So initially in the first line therapy, we can give them in the luteal phase only, like low dose and in the luteal phase. But if that is not found to be effective, then we can give them in throughout there. Then it can be given throughout the cycle can also be given. Luteal phase, basically we are going to give first line exercise, CBT, vitamin B6, then combine new generation pills, which should be given cyclically or continuously depending upon the circumstances and the extent of symptoms in the patient. Then we can give continuous or the luteal phase like day 15 to day 18 low dose SSRIs, and nowadays we give them citalopram and escitalopram, and the dose is low dose 10 mg. If that works, well and good. If it doesn't work for your patient, then we need to give second line therapies, like we can give estradiol patch, which is 100 microgram plus micronized progesterone, like 100 or 200 can be given from day 17 to day 28 of the cycle, orally or vaginally, or we can also insert levonorgestrel intrauterine 52 milligram system. Then higher dose SSRIs, they can be given continuously or luteal phase. For example, citalopram or escitalopram, now 20 to 40 milligrams per day can be given. If these are not working, then we can go to the third line management. That will be GnRH plus add-back therapy, which will have like estrogen, progesterone. Like we can give estradiol patches, and then we can give them 2 to 4 doses of estradiol gel, which is combined with a micronized progesterone, or we can straight away give them tibolone therapy. Doses you don't have to remember. If all first, first, second, and the third line treatments they have failed, then we will go to the fourth line. That is going to be surgical treatment plus minus HRT. For this patient, she is 37, so she will need HRT till the age of natural menopause. That is one thing. Then regarding the role of other medicines, they are like low risk pharmacological interventions. These include calcium carbonate because it is going to treat the bloating, food cravings and pains. Then magnesium can also be given because it can help with the water retention. It will push the water out. Vitamin B6, it can be used, but it is associated if we are taking it for more than like 6 months, then it is going to cause neuropathic neurotoxicity. And many other things like vitamin E and the NSAIDs, they have been used for cyclic edema, and also bromocriptine has been used for nostalgia. Okay, then the traditional drugs, they have not been found to be very helpful like that. And these antidepressants, these will be prescribed by the psychiatrist, and they can also add anxiolytics, because if sometimes the patients, they will have so severe nervous symptoms that they will not like to go out of the house, and then they will panic. So for such patients, the psychiatrist will add alprazolam and Vispiron. Both are anxiolytics. Okay, so you don't have to remember the name. Just remember that SSRIs can be given, and in the last stage, when the patient becomes homebound because of the fear of the symptoms, then we have the option to give them anxiolytics. Hormonal interventions, they have been found to be very helpful, and the GnRH, that is most highly favored, but the problem is that it can cause bone loss. That is one concern. CBT is very helpful, and the patient should be concerned about her condition, that this is not a disease. This is we are responding to certain level of hormones in the body. That's why we are having these problems. And then I will give her patient information leaflet. She will go over the therapies, and then from that point onwards, we can manage her like that. So just remember the keywords are the SSRIs, hormones, GnRH, and if she's going for hysterectomy and total abdominal hysterectomy and the bilateral oophorectomy, then we will have to give her HRT, and then this patient can develop the symptoms again. Role of vitamin E and other regimes, still, it is known to decrease the symptoms, but the vitamin E oil, primrose oil, pyridoxine. But the efficacy of these non-hormonal regimes is unpredictable. However, combination of these with psychotherapy, it has been associated with better results. Okay, that's all you need to tell here. So you have seen that.
This conference will now be recorded.
Hello, Sarah. Okay. Okay. So what can you tell us about this patient? Hello, Sarah.
Maybe she muted her microphone.
Yes.
Doctor?
Yes, dear.
Yes. So she's 19 years old with primary amenorrhea. I would love to ask her more about her history. I would confirm her age. I will ask her during her childhood, does she had any history of urinary anomalies or not, or any abnormalities during her childhood, any anomalies, any diseases. Then I would ask her about secondary sexual characteristic. Does she had her breast growth? Does she had pubic hair? I would confirm her height. I would ask her about her family history. Does anyone from her family has the same complaint or not?
about her educational level, how is she doing, how is her school performance, does she has any other medical problems, any surgical before, was she investigated before for this problem, does she receive any investigation, any diagnosis, any treatment before, is she sexually active or not yet, was she able to be or not. I will ask her also about general history about her. I asked about medical history, surgical history, medications history. I would ask her about social, smoking, alcohol, substance abuse. I will ask her about her vaccines. That's it regarding the history. What is written that the BMI is 17. I want to know her height.
Yeah,
And regarding the physical examination, when it is mean that physical examination is otherwise unremarkable, does it mean that secondary sexual characteristics are there
yeah,
and she has normal external genitalia?
yeah. She has normal genitalia and she has developed breast. That's why we are saying that she has good developed secondary sexual characteristics, and her height is like 170 and her weight is 50 kg.
170 her height. Okay. Then I would proceed with her regarding physical examination. Unfortunately, here I cannot go further with her. Though ideally, I should if she is I should examine her vaginally, looking for is there is vaginal pouch, or I can see a cervical. Initially, it's external genitalia looking, and if there is a hymen or not, is there is imperforated hymen or not, but in this case is unlikely. I would go with checking her vaginal length and cervix, and also she should have a PR examination, and for assessment if there is I can palpate PR regarding the vaginal length and the cervix assessment. But as it is limited here, I would just go proceed with ultrasound. And I would ask for hormonal profile, FSH, LH, and testosterone. But I'm sorry, I cannot exactly recall which one I should ask for.
Which one? No problem. It's okay.
Yeah. And based on the primary results of the ultrasound, I would go further. In this case, as she has normal secondary sexual characteristic, I would my differential diagnosis is between Müllerian agenesis or testicular feminization syndrome. So if by ultrasound I could, if I ruled out the diagnosis of Müllerian agenesis, I would go for karyotyping for this girl after the ultrasound.
Yeah,
After
ultrasound they did ultrasound and uterus was missing. And she has normal axillary and pubic hair. So what is your diagnosis?
So only absent uterus. What about the upper part of the vagina and the cervix? Are they also missing or not?
Yeah, blind vagina.
Blind vagina.
So total absence of the uterus, and the pubic and axillary hair, they are appropriate according to her age.
Okay, and normal breast development.
Yeah.
So okay, so my diagnosis would be Müllerian agenesis, Meyer-Retinsky syndrome. In this case, I would disclose information to the girl herself. I will explain to her. First of all, I should check about the environment of the today, and I ask her about her knowledge about her problem, and if she's interested to know more about it. Then I would explain to her the problem that she has um, regarding in a very simple way that she has a normal a female genetic she's a sexual
Genotype, yeah.
female
Yeah.
but and she has ovaries but her problem that she does not has a uterus and upper cervix, which they all come from the same genetic origin. That's why they are all missed. In her case, she would not be able to be menstruating, and also she cannot be getting pregnant by her own. She can, but still she can be sexually active with the help of dilators and informing and with the help of the dilators. Then I would inform her that regarding the pregnancy, unfortunately, she cannot get pregnant by her own. She can get pregnant by using a surrogate mother, or she can get pregnant. There are a very limited case reports regarding uterine transplantation, but this is done in the Middle East.
Yes. But she can have her own genetic children, right?
She can have her own genetic kids with a surrogate mother.
Yeah, that is one thing.
And she would not have problem. She would not have problem regarding the osteoporosis and those things because she has functional ovaries. That's why she had normal breasts. She has normal distribution of woman hair. She had normal growth as a woman.
Yeah. So that's why you don't have to give her any therapy. But if the patient has like Turner syndrome and she's having this premature ovarian insufficiency, then of course you have to give her full therapy like that. Or anyone whosoever has developed premature ovarian insufficiency due to any cause, idiopathic, due to infection, autoimmune, whatever was the cause, there also you need to give them HRT. You can give. So if the woman is young, then you have the option to give them COCPs in a cyclical manner. And if the woman is like 45 plus, then you will have to give her HRT like that. So that is also. And then psychotherapy, cognitive behavioral therapy is very important for such children. You have to tell them. What will you like to tell her?
After explaining her that she needs we need always to address her, and we need always to be seen followed up, and she would be instructed. We can help her by referring her to psychologist and trying to see her initially frequently, and whenever she coped with her problem, she can also again be seen after getting married to explain to her how she could go with using the dilators.
Yeah, and cognitive behavioral therapy is also very important. We need to tell her that this is genetic due to genetic makeup, and she is not alone. Many successful women in the world, they had the same genetic combination, but they are athletes, they are gold medalists. So it's not her fault. And if she has excessive stress, because it will come as a shock to her, so we will offer her cognitive behavioral therapy. That is very important. Like that. So here, I didn't show you the results. She had all of these, the hypogonadism like that. So once we will finish, please go over full report and the stuff like that. Okay? That is one thing. So very important relevant history. This woman is underweight, so we need to ask that does she have any self-induced vomiting or she's abusing laxatives, and does she have any psychosocial issues? Is there any stress? Then she has never been sexually active, so no chance of pregnancy, and no specific medical history of relevance, and fertility not a current priority, but would like children in the future. That is her history. Patient's main priority is to understand the reason for her amenorrhea, and she has no apparent body image anxieties. So further investigations, no GnRH causing lack of ovarian activity, showing the lack of ovarian activity. Prolactin is normal, and but need to check other pituitary activities, which is likely to be normal. Karyotype needed to exclude Turner's androgen insensitivity or similar possible links to the low BMI, despite lack of other features of anorexia nervosa. It could be variation of the normal range. Need to check pituitary hypothalamic function, progesterone challenge test, possible GnRH challenge test. Secondary characters, they need to be ascertained and not necessarily at this point, but she needs examination and initial pelvic examination. If she's coming only for this amenorrhea, you will have to do in internal examination, not at such, but we have to do the pelvic ultrasound first of all to see that the uterus and ovaries are present or not. This is the general template. Okay, it can be modified according to the additional information which is given to you. Some assessment of the bone age may be helpful. Any information on her growth pattern, it may indicate if she's still pubertal, because maybe she has a simple thing like delayed onset of maturation. It can also occur. Okay, then pelvic ultrasound scan. So if, like I told you on the scan, that no uterus, so the things will become clear and normal here, so one diagnosis established. Otherwise, any information on her growth pattern may indicate if she's still pubertal. Assessment of bone density, it may become relevant later, but not at this point like that. The treatment options, wait and see if like no other cause is found. This is when you have not found any cause. If you have found cause, then you are going to focus treatment on the cause. Refer to the dietitian. If the only problem is that her BMI is very low, then we need to refer her to the dietitian and advise on her diet aiming to increase her BMI. Particular relevance of optimizing bone density achieving at her age. Then check dietary calcium and the vitamin D intake, suggest appropriate weight bearing exercises, issues relating to the possible karyotype abnormalities. I gave you the cause, but if the cause is not there, then you don't have to discuss. Like they're not giving you any specific cause, then you don't have to do anything. Then you have to see that how the rest of the things are there, because she's just like very thin, this lady. Standard low dose, if the uterus has been found, in that case, you can start her on a standard dose of COCPs. So it could be appropriate once further investigations results they have been reviewed to provide normal estrogenization. Like when the uterus has been there, they have told you uterus is there. And then we can give her this one, optimize the weight, and then give her this estrogenification and the progesterone. And if she's having withdrawal bleeds, that means she's fine. Then counseling should be neutral and broadly reassuring of likely achievement of the normalcy. This is when they have told you that the uterus is there. If they give you this information that uterus is not there, then you are going with the general diagnosis of MBA and you are justified in saying what you told me like that. So many stations, they can be like, they can take unanticipated routes also. Don't be startled, okay? Just whatever information they will give you, just listen to that carefully. That is the point. Okay? Yes, that is the point.
This conference will now be recorded.
So the consent for both of these procedures, it should be on your fingertips. Which instruments you are going to use, what are the indications, what are the contraindications. More of it we are going to do tomorrow. This just came by chance, so that I showed you here. So that is the point. And the consent, and just remember one or two main complications. It's not possible to remember like 15 consents and 15 procedures like that. Okay, what is the risk of death, what is going to happen to her, what is her course during expected course, how she should recover, who will be on the team, and the pre-assessment like he has told. All of these things we need to evaluate very well before taking the patient to OR, because if she has good score, ASS score, and her lab results are fine, then we can anticipate that her post-op period will also be very smooth like that. Okay, so that's why all of this information is very important. So spend time especially on this general gynecology and also these surgical procedures. Why I tell you so? Because the urogynecology, subfertility, oncology, all these three are very specific fields. Okay, so even if you will not perform as they expect you people to perform, still you are going to be fine. But other things like general gynecology, in which you can have a spectrum of conditions here, Then this family planning and contraception. These three modules, they are not going to be very lenient, okay? So better focus on these things and the surgical procedures that are your domain, okay? These three subspecialties, if you are performing like they expect you to perform at level 19 and you are performing at 13, still they will say, no, it's okay. It's not their job. But the remaining three modules, no one is going to excuse you, okay? And always focus more on the common things. If you feel that you are stuck during exam, just forget whatever they are asking you or anything bookish. This exam is very practical. Start telling whatever you do in your daily practice and you're going to be fine. So, okay, doctors, thank you very much for attending. See you tomorrow at the same time. And the modules are going to be the general gynae, and then we will go to the half time for the general, or maybe less, maybe 1 hour for the general, and then 2 hours for the core surgical skill in the gynecology, including both the open procedures and the lab procedures. Okay. So inshallah, your notes will be available, video will be available. So thank you very much for attending. And in case you have any question, we were not clear about anything, then please feel free to ask me or to post in that group. Thank you very much.
Thank you, Dr.
Welcome,
Bye.
doctor. Bye.